We're good now. Okay. So just know too high or too little. So this lecture, we're only going to be discussing the pituitary and the hypothalamus. Yes, thyroid hormone is there. Cortisol comes through. ACTH is there. But we're only going to focus on diseases as they relate to the pituitary gland or the hypothalamus. We have separate lectures for the adrenals, pancreas, and thyroid. Okay? So we're going to focus on the pituitary and the hypothalamus for today. Remember your boxes. Okay? They'll come back again for this exam. So they go back to your physio notes if you did all those boxes like pituitary, then the hypothalamus, and whatever the target organ was, and all those negative feedbacks, they're all going to come back. So here's our hypothalamus, and we know it comes down to the pituitary gland. We know we have two sides of the pituitary, the anterior and the posterior. Make sure you know what hormones come from which side. Very, very important. I also bring this up because of this part right there, that sella turcica, and what also goes through this channel. It's not pictured here, but also is going through this channel where the sella turcica is. The optic nerves, the optic chiasm is here as well. So when we start talking about pituitary tumors, this pituitary gland is going to get bigger. And if it compresses the nerve, then you start getting visual problems. That's usually one of the signs that you'll see with pituitary issues. So hypothalamus, a lot of major functions with the hypothalamus: temperature, volume, osmolality, satiety, body fat content is all monitored by the hypothalamus. Coordinates nervous, endocrine systems, and responds to any deviations in lab values. Remember the stimulus, like we talked about PTH. What's the stimulus for PTH to come out? What about calcium? Low calcium levels. That's the stimulus. It's waiting for that, for a deviation from the set point, and then we have to correct the system to bring it back to normal. That's what the negative feedbacks are for. A lot of integrative functions in the hypothalamus. Heart rate, our RAS system activation is affected by this. Emotional response, our fear and pain centers, fight or flight, and also obviously very important in our hypothalamic pituitary adrenal axis, the HPA axis, in regarding stress responses. Here's just a review again. Hypothalamus releases GnRH, which stimulates FSH and LH. Growth hormone releases growth hormone. What is SS? Somatostatin. It's a red line, so we know it inhibits growth hormone. Remember, somatostatin inhibits growth hormone. So whenever you see somatostatin, just remember stop. Thyrotropin releasing hormone from the hypothalamus tells the anterior pituitary to release thyroid stimulating hormone. And that's going to go to the thalamus, the thyroid. DA. What did we learn that inhibits prolactin? Dopamine. So the DA is your dopamine. And the last one is your corticotropin releasing hormone. And this tells the anterior pituitary to release ACTH, which will then go off to the cortex. So your HPA axis again, remember, do your boxes. Hypothalamus, CRH, goes to the pituitary to release ACTH, which go to the adrenal glands, which then release cortisol. Cortisol has a negative feedback at the pituitary and the hypothalamus, so it tells both to shut off. We have enough cortisol, we don't need any more. ACTH will also have a little short negative feedback loop on itself on the pituitary gland to shut down ACTH production as well. The biggest influence is the cortisol. And then here's just another way of looking at it again. Remember what causes each one to occur. Now, starvation causes the HPA axis to activate. Cortisol-mediated gluconeogenesis. What's gluconeogenesis? new glucose from other substrates, amino acids or trigs, making new glucoses. Okay, and remember, cortisol makes your blood sugar rise. Fight or flight response, we need sugar in the blood to provide energy for whatever it is we need to do. Pituitary gland, and that bony cavity called a sella turcica. Sometimes certain conditions, we're going to learn about it later. One of them is called Sheehan syndrome. Sheehan syndrome is pituitary apoplexy, where the pituitary gland has an infarct into the blood supply. No more blood supply to the pituitary gland. It's going to shrivel and go away because no blood supply to it. And they get what's called an empty sella turcica, or empty sella. There's no pituitary gland in that sella turcica anymore because of a condition called Sheehan syndrome. We'll get to that in a little bit later. Also known as the middle manager because it's between the hypothalamus and those target organs. So the pituitary is in the middle. Two parts, an adenohypophysis, which is the anterior lobe, so it has the word adeno in it. It's referring to the hormonal part. The posterior pituitary is the neurohypophysis, which means it's stimulated by neural input. Remember, the posterior pituitary has a neural input so that it can release what two hormones very fast? ADH and oxytocin. Hormonal effects take time. That hormone has to go release from the pituitary gland or wherever, go through the blood system, go through circulation, find its target organ, bind to it, have its effect, and then something else is going to happen. It takes time. You guys can realize this when you eat food. If any of you have a glucose meter, after you eat, you see your blood sugar rise and it comes back down. It takes about a couple hours, but that's the effect of insulin. It takes a couple of hours for that to happen. But ADH, oxytocin will come out fast. Why is it important for ADH to come out fast? What is it doing? What is the main stimulus for ADH to come out? Not so much water retention. What is the hypothalamus looking at? Osmolality. Okay? Solute concentration. That tells you, are you dehydrated or overhydrated? How is your solute count? When it goes really, really high, we're really dehydrated because there's more solutes than solvent, and that stimulates. Okay. So again, review, remember what hormones come from what. ACTH, stimulation of adrenocortical cells. Again, the main goal of ACTH is corticosteroids. Okay. Related to circadian rhythm, again, cortisol. When does cortisol come out? In the morning, and it allows us to wake up. So cortisol spikes in the morning, wakes you up, which is why the whole 3 a.m. thing, if you wake up around 3 a.m., it's a cortisol spike and it wakes you up. Because your body's thinking, oh, we need to be awake now. Cortisol is coming out. Half-life in human blood is about 10 minutes for ACTH. Growth hormone is stimulated by, obviously, the releasing hormone. Fasting and hypoglycemia, they kind of go together in a way. If you're fasting, your sugar level is going to drop. Exercise will bring more growth hormone out. ADH, dopamine. The other really big thing that's not really here, sleep. Growth hormone comes out at night when you're in sleep, in deep sleep. That's why rest is so important if you want to grow and get muscles. You got to sleep. You got to rest. That's when growth hormone comes out. It's inhibited by somatostatin. We know that. Everything somatostatin is going to stop things. Hyperglycemia. If we're fed, there's no reason for growth hormone to come out because we have enough sugar in our system. Cortisol, same reason. It's going to raise your blood sugars. You don't need growth hormone to do that as well. It'll cause diabetes, which is why sometimes people take growth hormone for too long, they get diabetic because of the excess sugar floating around for so long. Pregnancy will inhibit it. Obesity will inhibit growth hormone, and your beta-adrenergic drugs can do it as well. The effects of growth hormone in the muscle, protein synthesis, we want to make more muscle, and decrease glucose uptake. So keep it in the blood. In the liver, increase protein and RNA synthesis, increase gluconeogenesis. When growth hormone comes out, let's say during a fasted state, okay, you're doing intermittent fasting or you're doing like a 2-day fast where you're just drinking water. As your blood sugar starts to drop, what hormone is going to come out? Growth hormone, because you're fasting now. Your blood sugar is dropping. So growth hormone comes out. And growth hormone is going to cause gluconeogenesis. What do you think are the substrates that growth hormone is going to cause to be one of those substrates? Fat. Growth hormone stimulates fat lipolysis. So you're going to lose fat with growth hormone. And that growth hormone is going to cause breakdown of fat to make more glucose so that your body can survive. That's why intermittent fasting works. If you still eat 3,000 calories of junk, it's not going to matter. But as far as the inflammation and all that stuff, intermittent fasting works for that. And growth hormone allows you to lose weight because you'll be burning fat. You need glucose in your body. It's the only energy source we can use. We got to make it from somewhere. Growth hormone come out, you start burning fat, you lose fat mass, and you get energy. So adipose tissue increases lipolysis. It's going to break down the fats. Use it as a usable substrate so we can make glucose from it. You'll see when we get to insulin, it does the opposite. So when you eat too much carbohydrates, insulin takes all those sugars and puts them as fat in your body, and you store it as fat. That's why overeating causes weight gain, because you're having too much carbohydrates, too much insulin, and it stores it as fat if you're not using it for energy. Okay? If you're sedentary all day, you're not using that energy for any reason, it's going to store it as fat, and you gain weight. And bones, heart, and lungs, obviously we need to grow. So all these things are just so that we can grow to our adult size. Now, the important thing with growth hormone, it stimulates IGF-1, that insulin-like growth factor. This is the real thing that growth hormone is going to do. It releases insulin-like growth factor, and this IGF-1 is the one that causes a lot of the growth. Similar effects to insulin, but growth hormone causes IGF-1 to be released, which causes the growth to occur without the negative side effects of the insulin. Prolactin, increased by obviously pregnancy, breastfeeding, sleep, so on and so forth. Dopamine antagonists. This is very important because what we give to patients who have prolactinemia or prolactinoma, so they produce a lot of prolactin, we give them dopamine. It's going to stop it from being released. So it's secreted, decreased secretion by dopamine, bromocriptine, somatostatin. These two, dopamine and bromocriptine, are the two drugs that we give to patients who have a prolactin tumor, because it's going to stop the secretion of prolactin. What do you think people are going to present with if they have a prolactinoma, high prolactin? Galactorrhea. And especially in men, it's a very clear sign this patient probably has a pituitary tumor if it's occurring in men. And milk production, of course. TSH tells the thyroid to make our two thyroid hormones, T4 and T3. TRH is the one. Somatostatin is here as well. Here is our feedback loops. I'm not going to go crazy right now because we're going to do a whole lecture on thyroid. But you guys should know this one already, these feedback loops from physio. FSH, we don't go into anything right now in this class regarding reproductive abnormalities. You will get all that with OB-GYN in the winter, all the reproductive issues with FSH and LH. But again, in the ovary, follicle stimulating hormone is going to stimulate the maturation of the follicles. In men, FSH goes to the Sertoli cells of the testes, and it's helpful for spermatogenesis. So FSH is both making the things that we need to reproduce, the egg and the sperm. Think of it that way, FSH, eggs and sperm. LH, in women, triggers ovulation. In male, Leydig cells to make testosterone. Okay, and they're both regulated by GnRH. Okay, so here's your feedback loops. One important one to note is this inhibin. Remember that inhibin only affects FSH. So that inhibin feedback is only to FSH, not LH. That's what the inhibin is for. Okay, posterior lobe, ADH, oxytocin. ADH is stimulated by upright posture, so that orthostatic hypotension, exercise, insulin, diuretics, beta, cholinergic and adrenergic drugs, stroke, hemorrhage, and so on and so forth. Inhibited by high blood pressure. These two things go together, diabetes insipidus and SIADH, having to do with the release of antidiuretic hormone. SIADH has too much ADH. Diabetes insipidus has too little ADH. That's why I said before, when you're studying the hormones, what effect does having too much of this hormone have? What effect does too little hormone have? Remember, with vasopressin or ADH, there are two types and two receptors for vasopressin. V1 is in our blood vessels, and they cause constriction. They're going to cause our blood pressure to go up. The other, V2, is in the kidneys. Okay? Increased blood volume. It's going to allow what type of solution to go into the blood from the kidneys. When ADH stimulates these V2 receptors, what is being absorbed or reabsorbed back into the blood? Sodium-free or solute-free water. It's just water. There's nothing else in it. What other hormone has also a way to get water back in, but it also requires something else? Aldosterone. So sodium and water both come in. With ADH, it's just free water. Nothing else is in it. Here's our feedbacks again. Solute concentration is the stimulus when it comes to ADH release. So the effects of ADH, okay, increase the permeability of renal distal tubule to water in the common collecting ducts. So less free water is excreted in the urine, so our urine volume decreases because we're going to reabsorb it. ADH is telling us to hold on to this water, so we're not going to lose it. So it stays in the blood. Remember, we don't care about the concentration of the urine. It's just waste product. It's a way to get rid of water, electrolytes, other things. It's a waste system. So urine volume is decreased. Because the amount of water going into the urine decreases, the concentration goes up. Less water, more solutes in the urine osmolarity goes up. What happens to your blood osmolarity? Goes down. Because we're adding water to our blood, it's going to dilute it out, osmolarity drops. Therefore, once osmolarity goes back to its normal range, the stimulus shuts off and ADH stops secreting. And that's the feedback for ADH. Oxytocin, stimulated by cholinergic nerve fibers. So in the breast during nursing, oxytocin released in the blood. 30, 60 seconds later, milk letdown. Okay, could you imagine if for women to breastfeed their child, once the baby starts crying and was hungry, it took 2 hours before you started letting down milk? No, it's got to be faster. That's why these neuroendocrine hormones, posterior side, are neurally stimulated, so they can happen faster. Okay, we talked about insulin. It takes a few hours for its effect, but oxytocin happens fast. It's also like the love hormone, so hugs. If you get a hug from someone, you feel better. It's because oxytocin has been released, and you feel better when that happens. That's why physical touch, that's why I tell you, well, I haven't told you, but when you're doing your physical exam, okay, excuse me for a second. When you're listening, put your hand on their shoulder while you listen to their heart and their lungs. Just put your other hand on their shoulder, okay? It's just, you're not doing anything, but it's just calming them, lets them relax, and so forth. Inhibited by emotional stress and anxiety, so decreased milk ejection during periods of very, very, very high stress. Alcohol also will decrease oxytocin release. And then obviously these are the effects of oxytocin: let down for milk and uterine contraction. Okay, very, very important for uterine contraction during labor. One of the drugs that we give to induce labor is called Pitocin. What does it end like? Oxytocin, because that's what it is. And when we give it to pregnant women, it induces labor because the uterine starts to contract. Once the uterine contraction happens, the baby will start moving down the birth canal. So that's what, and then, now conversely, if you deliver the baby and the mother is bleeding and the bleeding isn't stopping, we also give Pitocin or oxytocin again, which is going to cause what? Uterine contraction. What's the best way to stop bleeding? Pressure, right? Applying pressure. So we give oxytocin, which squeezes all those vessels, stops the bleeding, and it prevents that postpartum hemorrhage with delivery. Okay, so now let's talk about finally our disorders. So first one, hypopituitarism. Partial or complete loss of the anterior hormones. The signs and symptoms depend on which hormones are affected. Normally I say, guys, I hate when people order labs, just order everything and let's see what we find. That's a bad way to do medicine. However, in this case, if they have some signs of a pituitary tumor or they have issues with low hormones, you don't know which hormone it is. So for those cases, in pituitary issues, check all those hormones in the anterior pituitary. TSH, CRH, GnRH, GHRH, growth hormone, all of those things. You want to make sure that the pituitary is being stimulated appropriately. So you need the releasing hormones, right? Because if the releasing hormones don't come out, will the pituitary gland do anything? No, because the hypothalamus tells the pituitary what to do. So you have to check all these labs. So you check everything. Onset, usually insidious, can be sudden or dramatic. Growth hormone is usually lost first, then your gonadotropins, and then finally TSH and ACTH. So patients are coming in, they're not as tall as they should be, they're not growing up, and so on and so forth. Check all that stuff. If they have a lack of LH and FSH, in children, delayed puberty. These are the hormones that are needed to start puberty, and they're not going to be there. In premenopausal women, amenorrhea. Okay, nothing is telling the follicles to be stimulated. So therefore, the menstrual cycle never starts. Therefore, they lose it. Decreased libido, regression of secondary sex characteristics, and infertility makes sense because there's no FSH to stimulate the hormone, the follicle to be released or matured. There's no LH to cause ovulation, so it never happens. In men, erectile dysfunction, testicular atrophy. Again, if you're not stimulating these glands, they're not going to grow and they'll shrivel up and go away. That's why one of the side effects for guys who use a lot of testosterone, testicular atrophy, because they don't need the testes to make testosterone anymore. They're taking it via needle. So you don't need to use your testes for that, so they shrink. And that's why men on hormones and all that stuff get testicular atrophy. And same thing, decreased spermatogenesis for the same reasons in women. Nothing is telling the sperm to mature and grow. There's no FSH around to do that. So etiology, the majority of them are these pituitary adenomas. They start compressing those adjacent tissues. Here's your Sheehan syndrome I told you before, postpartum pituitary necrosis. Okay, during childbirth, they had severe hypovolemia, something happened, and they lost blood supply to the pituitary gland. It's going to necrose and die off. Pituitary apoplexy, very similar, just has a different cause, but again, problem with the pituitary gland, either iatrogenic or bacterial viral causes. So here is Sheehan syndrome, again, postpartum women. So I don't mention anything in the question about a woman delivered baby 3 weeks ago. It can't be Sheehan syndrome because it's only in postpartum women. Okay. Pituitary necrosis from hemorrhage or hypovolemia, shock in that immediate postpartum period. So what's going to happen? No lactation. Why no lactation? There's no prolactin, right? Can't make milk. Prolactin makes the milk. Oxytocin is the letdown. Make sure you know those two, what they do. They're different. Fatigue, loss of pubic and axillary hair. Pituitary apoplexy is a hemorrhagic infarction of either a normal gland or a pituitary tumor. So the resulting edema may compress the hypothalamus. Remember, the hypothalamus is our alert center, awake sleep cycles. If you compress the hypothalamus, you can cause problems, and then you get sleepiness and somnolence. And they may have vascular collapse because they don't have any cortisol or ACTH. Okay? Acute symptoms, severe headache, stiff neck, visual field problems, oculomotor. A lot of common symptoms for stiff neck could be meningitis. There's other things that there could be with these complaints, but if they come in with complaints of a headache or they have symptoms of other problems, they're very sleepy, somnolent, check your hypothalamus hormones. Pituitary tumors make up 10% of all intracranial tumors, mostly benign with these pituitary tumors. And whenever you see the tumor, think of excess. If they have a tumor, they're going to secrete more hormone than they should. There are 3 different types of adenomas for pituitary gland, and they're all based off of location and what tissues are involved. So a lactotroph tumor causes issues with prolactinoma. Somatotroph tumor, growth hormone excess. Corticotroph tumor, too much ACTH. Okay. Craniopharyngiomas are mainly more common in children. So craniopharyngeal canal, so during development, cranial and pharyngeal structures arise from this area. Meningiomas, metastatic tumors can also be causing these pituitary tumors. So prolactinoma is the most common one. The visual changes, that tunnel vision because of the compression of the optic chiasm. So bitemporal hemianopia is what you get, tunnel vision. You can't see the peripheral, only middle. So severe headaches. Why are they having headaches? What's growing in their brain that shouldn't be there? A tumor. You have a mass growing in your brain that shouldn't be there. It's going to push on the corresponding structures, causing you to have a headache. Bitemporal hemianopsia because of the optic chiasm, loss of central vision is the same thing, and maybe some oculomotor palsies as well. Loss of temp regulation, excessive hunger they also have with these prolactin tumors. And then again, here is our picture of our optic chiasm and our pituitary gland. And here's your bitemporal hemianopia, or opsia, whatever language or book you're reading. So that's it on prolactin. Not much. Too much prolactin, what does it cost? Pituitary tumors, growth hormones. Now we're dealing with our somatotrophs. Soma is body, so that's where the growth hormone comes from. So gigantism and acromegaly are the 2 conditions with high growth hormones. The difference between the 2 is when it started. Gigantism begins in childhood before closure of the epiphyses, those growth plates. Okay, so when you see kids in high school who are like 7 feet tall, they probably have gigantism. Okay, that's not normal to grow that fast, that early in life. They probably have, I'm not saying for sure 100%, but they probably have some sort of growth hormone issue. It is relatively rare. Skeletal growth velocity and stature are increased with little bony deformity because the growth plates haven't fused yet. Those bones can elongate like a normal body type. It's the other one that causes all the issues, the acromegaly, which we'll get to in a second. Soft tissue swelling occurs. Peripheral nerves also get enlarged. So everything grows. They may have some delayed puberty or hypogonadotropic hypogonadism. That sounds like it's repeating itself, but it's not. So the first part, hypogonadotropic, is referring to what? The releasing of the hormones, right? So we're not having enough hormone being released. Therefore, that results in hypogonadism. And what's hypogonadism? Hypogonadism is small testes. Okay, undergrown testes. So because they don't have FSH and LH in the right quantities coming out, testes don't grow because nothing is stimulating the testes to make testosterone. So they get delayed puberty. This is gigantism, a 12-year-old boy, pituitary gigantism, 6'5". He's 12. Eli's 5'3", or 5 foot. He's same age, 12. So this guy's 6'5", he's 12. Also enlarged hands, look how big that hand is. But it looks proportional. He looks proportional. He's tall, but his body is still proportional because the gigantism was before those growth plates fused. And here's another picture of gigantism. Again, very, very, very tall, but looks in proportion. Now, let's talk about acromegaly. Okay, acromegaly, growth hormone hypersecretion after the epiphyseal plates close. So the growth plates have closed. With acromegaly, they start getting a lot of changes. Coarsening of their facial features, appearance changes. Soft tissue starts to swell. Their hands and their feet get huge. They'll notice that normally they were wearing rings, and now the rings don't fit anymore because their hands are getting big. You'll see their hands are huge. So photographs of the patient are important to delineating the course of the disease. So this is some of the features with acromegaly. Very, very pronounced jaw. Ridge in the brow. Okay. So overgrowth of the mandible, prognathism. Increased coarse body hair, skin thickens. High perspiration, very bad body odor because of the glands, the sweat glands get bigger as well. And you get cartilaginous proliferation. So the larynx starts getting thicker, deep, husky voices. Okay, if you guys know wrestling, Andre the Giant had acromegaly. If you ever hear his voice, he sounds very low and deep because of the thickening of the larynx caused the voice to drop. Enlarged tongue, costal cartilage growth, giving him a barrel chest. Look at this person's feet due to acromegaly. Okay. Articular cartilage undergoes hypertrophy, so they get a lot of joint problems. They get a lot of peripheral neuropathies just because of the soft tissue swelling. Those nerves that are in the area get compressed. If you compress a nerve, it causes the pain. It's like carpal tunnel syndrome. It's due to a compression of that nerve. It causes the pain. Heart problems. Okay, the heart is going to increase in size as well. Diabetes occurs in 20% of these patients. Why? Excess GH causes excess glucose in the blood. I said before, if you're on growth hormone supplements for a long time, you might get diabetes because of the excess sugar being dumped due to the growth hormone. Hypercalciuria, therefore renal stones can develop, and symptomatic hyperprolactinemia. So here are the differences between acromegaly and gigantism as you are studying your stuff. Another pituitary tumor deals with ACTH, and now we're talking about Cushing's syndrome. Okay? Cushing's syndrome is an umbrella term. It involves really excess cortisol. There's different types of Cushing's. You can have Cushing's disease. So if you have Cushing's disease, that means the problem is with the pituitary gland itself. So if you see a question on your exam that says Cushing's disease, it's only related to a pituitary problem that's causing the high ACTH. Cushing's syndrome is any reason for having high cortisol levels. If you're taking prednisone every day because you have rheumatoid arthritis or whatever, that will rise your cortisol levels, giving you a Cushing syndrome if you take too much of it. If you have a tumor in the adrenal cortex, that's dumping out cortisol. That will be high as well, but the problem is with the adrenal gland, not the pituitary. So disease is the pituitary gland. Syndrome can include the pituitary, but it's just a general term. So etiology, exogenous administration of corticosteroids, or ectopic ACTH, or a cortisol-producing tumor. So a tumor could produce ACTH. A tumor can also produce cortisol. Okay, your job is to figure out where is it coming from. So possible causes of Cushing syndrome, endogenous causes. Here's your pituitary tumor, Cushing's disease. That's the main one. 70% of these cases are going to be this one. The next one down could be an adrenal tumor, or you could have a tumor somewhere else. The big culprit for this one, lung cancer. Lung cancers, there are some of them called oat cell cancers that can start producing ACTH on their own. The problem with that, where is the negative feedback for ACTH? Pituitary gland. Why the pituitary gland? It's got receptors for ACTH to turn it off, and got receptors for cortisol to turn off the pituitary gland. We have too much. The problem with these oat cell tumors, they don't have receptors for ACTH or cortisol. So they just keep pumping out ACTH. Nothing stops it. But you have a tumor in your lung that's producing ACTH with no negative feedback. It's just constantly being secreted ACTH. Does your adrenal cortex know, is this ACTH from my pituitary gland or from this tumor? It doesn't know. And then you get high cortisol. So we got to figure out what causes these things. So I'll get to that in a second, what we do. But again, Cushing's disease is the most common one, and it's a tumor in the pituitary gland itself. So signs and symptoms of Cushing's disease, central obesity, okay, all that excess cortisol. You hear a lot about cortisol belly, okay, inflammation in the abdominal cavity. It's all from the excess cortisol. A moon face or a buffalo hump. What happens with excess cortisol, we start redistributing the fat, and the fat will start collecting on the face, giving them a round face, or the fat will also go on your little hump here, like where C5 is, I think. Your little hump right there, it collects there, and we call it a buffalo hump because you have fat collection right on your neck. Gives you the appearance like a buffalo hump. Hypertension, glucose intolerance, so they may have some diabetes. Purple striae is a very, very big one that you'll see with Cushing's, these deep purple striae. Muscle wasting and weakness. So basically what these patients turn into, they have a big belly and little legs. Arms and legs atrophy, they go away, but the belly is still big because of the cortisol, so they get big bellies but small arms and legs. Muscle wasting. Osteoporosis and growth retardation as well from the excess cortisol being released constantly. So you can see here, this is the buffalo hump. Here's the moon face. And you can see there. If it's corrected, they can go back to normal. We had a student a few years ago that had Cushing's from something else, had the symptoms, but before she came to PA school, got treated, and everything went away. She showed me a picture of what she looked like before. I was like, wow. Because she really had the moon face and everything, but it goes away once you treat the underlying causes. So here's your Cushing's. I think I have all that stuff in the renal lecture. Okay, now we talked about the anterior pituitary gland. We went through growth hormone. We went through prolactin. We went through ACTH. Now let's talk about the posterior one. So again, too little or too much. Growth hormone too much, acromegaly, gigantism. What do you think happens when you have growth hormone deficiency? You're going to be small and short. Okay? Messi. Lionel Messi has pituitary problems growing up, growth hormone deficiency, got growth hormone. Now, growth hormone in those patients will just make them into a normal size. You're not going to make a superhuman by giving your kid growth hormone. It just gets them onto a normal growth trajectory. Okay, so posterior pituitary hypofunction is going to be your diabetes insipidus. Hypofunction, lack of ADH. You have central or nephrogenic, and the posterior pituitary hyperfunction is your SIADH, syndrome of inappropriate secretion of ADH. There's too much ADH. So DI has two types. ADH cannot be working for two reasons. One is central. We just don't make the ADH anymore. Posterior pituitary doesn't make it or hold on to it. The hypothalamus makes it. But we don't release it anymore from the pituitary gland. That is central DI. We're not giving anything. Also known as neurogenic DI. Any patient coming to the hospital with a head injury, you have to watch out for ADH problems. Watch their eyes and nose. How much urine are they producing? How much water are they drinking? You got to notice these things because they're going to have, it's going to be off. And the last one, or the second one, is resistance of the kidney to ADH. So the kidney itself doesn't respond to it. So we have ADH in the system, but doesn't matter how much ADH I give you, because your kidneys aren't responsive, nothing's going to happen. So one of the tests you can do is you give a patient ADH, and you see what happens. If you give them ADH and they have a response to it, what type of DI do they have? Central, why? The kidneys can still respond to ADH. So if I give you ADH, you're going to start diuresing because your kidneys are so responsive. If I give you ADH and nothing happens, we know it's nephrogenic because the target gland doesn't respond. Okay. Etiology, 33% idiopathic. Genetic mutations, here's the injury to the hypothalamus pituitary area. Car accidents, they hit their head, concussions, watch out for these things. Polyuria, polydipsia develop due to an inability to concentrate urine with subsequent chronic water diuresis. They're going to be drinking a lot of water because they're losing a lot of water. Get very dehydrated. Okay, your thirst mechanism comes from the hypothalamus. Okay, you need water, so they keep drinking. So with DI, here's just another summary slide. ADH deficiency, impairment of water reabsorption. So all the water stays in the urine. We don't have ADH to bring it back into the body. So it stays in the urine. So our urine volume goes up, way up, very high. All due to lack of response to ADH. Okay, so ADH is synthesized within the hypothalamus, but it's stored in the pituitary, posterior pituitary. This is the important part right here. Supraoptic paraventricular nuclei, again, of the hypothalamus, or portion of the pituitary stalk. That's where the damage comes in when it comes to central DI. Something happened to hypothalamus or that pituitary stalk. That's the communicating method between the top and the bottom. Pituitary stalk kind of like holds the grapes and then attaches to the hypothalamus. Okay, primary, again, nuclei in the hypothalamus are under a lot of problems. Genetic is the big cause for this one. Your secondary or acquired injuries, tumors, vascular lesions, and infections. Anything that causes problems in the brain, swelling of the brain, compression of structures, you'll have these issues. Or you could. That's why I always look for them. Here's just some more etiology ways to study if you want that. Onset of central DI may be insidious or abrupt, any age, but the big symptoms, polyuria, polydipsia. Polyuria, they're producing tons of urine, up to like 20 liters a day. Okay, that's a lot of peeing. Gotta keep going. And polydipsia, because you're very dehydrated. You need water, so you're thirsty, so you keep drinking a lot of water. Okay, so 2 to 20 liters a day of very dilute urine are excreted. And obviously nocturia goes up. You're producing a lot of urine, you got to go to the bathroom. So you're going to be waking up a lot to pee. Dehydration, hypovolemia can occur. If the patient is unconscious and they can't drink, they can develop hypernatremia. Okay, we don't like sodium very, very high. We don't like it very, very low either. Okay, watch out for that. So that's low function of ADH, DI, diabetes insipidus. Now we have too much. We have an inappropriate release of ADH. It's just constantly coming out. Etiology, CNS disorders. Here we go with those injuries again. Drugs that can cause this. Chlorpropamide, carbamazepine are big ones that can cause SIADH to occur. Because SIADH is usually a result of a pre-existing condition, the symptoms vary according to the disease that caused it. Okay, so they have SIADH, but what was the underlying thing that caused them for this to occur? They're going to have those symptoms as well. So look at these causes. 1, tumors. Okay, different types of tumors can cause SIADH. Pulmonary lesions, pneumonia, okay, can cause SIADH to occur. Your CNS causes, big one, meningitis, tumors, head injuries. Okay, these are CNS causes that will result in an SIADH to occur. Your metabolic causes, alcohol withdrawal, and then drugs, here's your chlorpropamide, carbamazepine, and so forth. So these are all different causes, but if their issue is pneumonia and they have SIADH, guess what they're also going to have besides all these urinary problems? Fever, they're going to look sick, maybe some problems breathing. Other symptoms, all related to the pneumonia, cause the SIADH. Hyponatremia, most common electrolyte disorder in hospital inpatients. Why do they get hyponatremia? Retaining too much water, right? We have syndrome of inappropriate ADH. We have too much ADH, so all that water is being sucked from the urine into the bloodstream. That's going to dilute out your solutes, causing hyponatremia. Okay, so SIADH is the most common cause of hyponatremia in hospitalized patients. That's why you check labs every day in these patients. You want to follow the sodium. Make sure it's not starting to drop. Okay, patient is hyponatremic, low sodium osmolality, which would normally inhibit ADH secretion. Okay, we have osmolality too low. We don't need ADH, but because our hypothalamus is messed up, something is wrong, these etiologies we learned about 2 minutes ago is causing this ADH to go crazy. Now we have, but we're still going, so we're going to keep making that hyponatremia worse, keep dropping that serum osmolality because ADH is going unopposed. So we're retaining too much water in the bloodstream versus urinating it out. So we have some compensatory mechanisms that try and kick in. First one, ANP. Where does ANP come from? Under what reason does it come out? High volume. What does high volume cause to the atria? Stretch. And when they stretch, that's when they release the hormone, because that means there's too much volume in the system. The atria should not stretch. That means there's too much volume, so we release atrial natriuretic peptide to help maintain our euvolemia by maintaining maintaining urine output. Okay? Remember, it's natriuresis. So what solute is being moved? Sodium. Wherever sodium goes, water goes with it. So on physical exam, usually going to be normal. They may have some hypervolemic symptoms as well. High blood pressure, maybe some mild edema from that increased hydrostatic pressure in the system, pushing the fluid out. You get a little bit of edema from that as well. So in general, Our plasma sodium concentration is the primary osmotic determinant of our ADH release. It's the sodium. That's the big solute in the extracellular fluid. Patients with SIADH, excess secretion, enhanced water reabsorption, causing a dilutional hyponatremia. Dilutional hyponatremia. That means the sodium levels are really normal. You just added too much water to it. But the solute concentration is still normal. You just added too much water. Does that make sense? Everyone understand that? We're adding too much water, it's diluting it out. The number of salt solute molecules is still the same. We've diluted it out because of the concentration. Same thing could happen with anemias. If you give someone their fluid overloaded, all that fluid is in the system, makes your hematocrit drop, right? But it's not really, you're not really anemic. It's because of all the excess water is diluting out your concentrations. Okay, volume receptors are activated, releasing ANP, which causes the natriuresis. Okay, more sodium in the urine, but also more water. So we're keeping the patient euvolemic, because right now they should be fluid overloaded, right? Because of all this excess ADH. But the natriuresis allows some water to still go in the urine, so our water levels are still the same. So euvolemia is a normal volume. So when you say euvolemic, it means they are the normal water levels for their body. Eventually, steady state is reached, and the amount of sodium excreted in the urine matches the sodium intake. When that happens, what should happen to your concentration of sodium? If they're equal, sodium will level out, and sodium will be okay. Concentration will be okay. Ingestion of water is an essential prerequisite for these patients for developing the symptom, regardless of the cause. And hyponatremia does not occur if the water intake is severely restricted. So for these patients, they get a sign on their door, they're only allowed to drink like 250 mLs of water a day. That's it. 500 mLs, that's it. Because if they keep drinking more, all that water is going to go into their blood system. What happens to their sodium? It's going to drop. If it drops too low in the 1-teens, you can start getting seizures. And so those neurological problems from that low sodium. So by restricting the water, we're lessening the amount of water that our body is going to absorb from our gut. Therefore, our blood volume is going to drop a little bit at least by restricting the water. Also, they may have an inappropriate thirst sensation, so they're going to drink more. But when they keep drinking all this water because they're very thirsty, it's going to dilute out their sodium even more, causing more problems as well. So they cannot drink water freely. They have to be regulated with SIADH. Okay, so what are they going to have? Very concentrated urine. Occasional cerebral edema. We never want to see anything causing cerebral edema. Not good. We don't want cerebral edema. When you have cerebral edema, you get mood swings, irritability, seizures, coma can even happen. Hyponatremia will cause water to flow into the brain. Remember we did first lecture of physiology. We talked about cells swelling and cells shrinking. This is where it comes in. Okay? So this is why we learned all that. Okay, it's going to pull water into the brain cells because there's a higher concentration of sodium in the cells than in the blood. Water is going to go to the higher concentration. Your cells swell in the brain, cerebral edema. And anorexia or nausea can also be there as well. So characteristics, hyponatremia on labs. They're going to have a normal volume status or maybe even heightened volume status. Low plasma osmolarity because we're diluting out all the solutes in the blood from all this excess water. Dilutes it out. Because we're retaining all this water, our urine volume drops because we're not producing any urine. Or if we are, what's the cause of any urine production for the most part? What's stimulating a lot of the urine production in these patients? What hormone? ANP. Okay, atrial natriuretic peptide comes out. Helps with the urine concentration. increased urine osmolarity, and urine sodium excretion. Lower levels mean there is sodium depletion due to hypervolemic-driven natriuresis. So, yeah. So we're going to secrete less sodium if it's, wait a minute. Okay, so there's two ways. Either we're not eating salt or we're losing it in the urine. So here's your summary slide between SiADH versus DI. How much urine do they produce? Where's the water? Make sure you understand the difference between SiADH and DI. And we'll take a break. Come back at 1:45.